Hi there. My name is Dr. Samuel Bauer. I'm a maternal fetal medicine specialist and an associate professor of obstetrics and gynecology here at Duke University. I'm really excited to speak with you today about screening for gestational diabetes. First, I have no financial relationships or disclosures to share with you this afternoon. This is an outline of what we'll be talking about here over the next few minutes, basically looking at a background and terminology, short and long-term risks of gestational diabetes, types of screening tests, and then I do want to spend a little bit of time just thinking about and talking about postpartum follow-up after a pregnancy complicated by gestational diabetes. So first, I want to talk just as some background. We know that pregnancy is associated with insulin resistance, and this really comes from the placenta itself. You get lots of placental secretion of growth hormones and corticotropin releasing hormone, placental lactogen, prolactin, progesterone, and other hormones. And because of this insulin resistance, you ultimately develop gestational diabetes because pancreatic function is insufficient to overcome this insulin resistance from the placenta itself. It's been advocated by many organizations to screen for gestational diabetes, but ultimately there is no universal accepted standard regarding the screening and diagnosis of gestational diabetes. Just from some terminology, keep it clean in your minds. Patients either have pre-existing or pre-gestational diabetes, or they have gestational diabetes. Life is never that easy though. There's sometimes where there can be some gray areas, but essentially pre-existing diabetes is type 1 or type 2 diabetes diagnosed before conception, or they have developed gestational diabetes. This is from abnormal glucose tolerance screening, really anytime in the pregnancy, typically between 24 and 28 weeks. But if a patient has had early screening, she essentially has gestational diabetes, but it may likely be pre-existing diabetes. Just as some background, if we think about prevalence of this condition, the traditional Carpenter-Kusten criteria are noted here, and that prevalence is around 6% or so in the United States, and a little higher when you use the National Diabetes Data Group data. And this prevalence is continuing to increase year after year, mainly we're thinking because of advanced maternal age, as well as BMI, as obesity continues to be prevalent in our populations. As far as associated risks that could increase a patient's risk for gestational diabetes, we think about hypertension, having a large for gestational age neonate or macrosomia, history of birth trauma, history of operative vaginal delivery, perinatal mortality. These are all things that can ultimately occur in a pregnancy when you have gestational diabetes. And there's certainly long-term risks from gestational diabetes as well. Mothers can go on to develop type 2 diabetes later in life, as well as cardiovascular disease. And those fetuses, neonates that then go on to become adults are at increased risk for obesity, for their own abnormal glucose tolerance, as well as hypertension and other metabolic syndrome. There are risk factors for gestational diabetes, including a personal history of impaired glucose tolerance or an A1C greater than or equal to 5.7, history of gestational diabetes in a previous pregnancy. Those patients can be at as high of a risk as 40% for a recurrence. Family history, especially in first-degree relatives. Oftentimes, we look at a lot of weight during the pregnancy, but the best marker is a BMI of greater than 30 pre-pregnancy. Patients that are greater than 40 years old, polycystic ovarian syndrome, Hispanic Americans, African Americans, and others, as well as a history of macrosomia in a previous pregnancy. Benefits from screening have been well documented within the literature. We know that screening for diabetes, when it's performed during the pregnancy, can allow for both lifestyle changes as well as therapies to help to reduce maternal and fetal risk, including macrosomia, shoulder dystocia, and preeclampsia. There's also cost implications from screening versus not screening, and this has been modeled in several studies. When you're looking at populations with a high prevalence of gestational diabetes as well as pre-existing diabetes, screening appears to be cost-effective in the prevention of type 2 diabetes, mainly because of the lifestyle changes that are able to occur when identification has been made. This is a list of candidacy for early pregnancy screening for gestational diabetes identified by the American Diabetes Association as well as American College. This is for patients that have a BMI equal to or greater than 25 plus one of these risk factors. You can see them on the screen, but a history of gestational diabetes, first degree relative, macrosomia, history of cardiovascular disease, hypertension, hypercholesterolemia, PCOS. Many of these patients can benefit from screening, and oftentimes these are these patients that may have this early screen that are gestational diabetes, likely pre-existing diabetes. We will talk about different types of screening tests in this presentation. There's a one-step test and a two-step test that have been advocated by the American College of OBGYN. Obstetricians, and here at Duke, we tend to use the two-step test. Regardless of the gestational age, others use a one-step test. And the most important thing in general is that you have standardized this throughout your health system so that everyone's talking the same language. I wanted to just remind us what our definitions for overt diabetes are. So if you have a patient that has an A1C at or greater than 6.5%, if they've got a fasting glucose of 126 or greater, fasting being identified as no caloric intake for at least 8 hours, or if they've got a 2-hour plasma glucose of greater than 200 after a OGTT, or just a random glucose, these patients have diabetes and should be managed as a pre-existing diabetic, where you're getting end organ damage evaluation, EKG, 24-hour urine or a spot protein creatinine ratio, ophthalmology evaluation. These are not patients that should be managed simply as a gestational diabetic. For patients that then screen positive early on in the pregnancy with the glucose tolerance test, again, these patients likely have gestational diabetes, or they do have gestational diabetes, likely pre-existing. And again, the management is similar to those with pre-existing diabetes. If it's negative, patients can be reassured at that time, and the next steps would be to follow up at 24 to 28 weeks with the traditional screening for gestational diabetes. If patients screened positive for the glucose challenge test early on with a 50 gram, they do not need to do the 50 gram again. They could go ahead and just do the 100 gram glucose tolerance test at that time. As far as screening goes, there is thoughts behind universal screening, and that's really what is most advocated for. We know that 90% of pregnant people in the United States have at least one risk factor for glucose impairment in pregnancy. And if you went by risk factor screening alone, we know that 20% of pregnant people diagnosed with GDM have no risk factors. As can sometimes be the case, a systematic review that was performed by the United States Preventative Service Task Force concluded that there's moderate net benefit to screening for GDM at 24 weeks. So that's helpful. That gives us additional criteria and foundational information to screen all of our patients in a universal way for gestational diabetes. Screening, again, is performed at 24 to 28 weeks. There's a 1 or 2-step process. There is no consensus amongst national or international organizations regarding the optimal approach. Again, clinical and operational standardization should be utilized. Screening can be performed after this time. If patients present late for care, they certainly should still be screened regardless of the gestational age. This is a table looking at the 2-step screening approach, which starts with a 50 gram glucose solution that the patient drinks can be given at any time during the day, and then a plasma or serum glucose is obtained 1 hour later. We will talk a little bit about the ranges later in the presentation, but essentially 130, 135, or 40 can be used as a positive screening test, which is then followed up with patients fasting, ingesting 100 grams of oral glucose, and then having blood drawn after the fasting, getting the glucose drink 1 to 3 hours afterwards. This represents the glucose evaluation for patients in the one-step approach that is advocated through the American Diabetes Association, as well as the International Association of Diabetes and Pregnancy Study Groups, 92, 180, and 153. And this is a 75 gram glucose load. So you may be thinking, well, which one should I do? There's certainly literature on both sides of these screening tests. There is a meta-analysis that was in 2018 that looked at 4 randomized trials of a little over 2,500 patients, compared the 2 approaches, and essentially in this meta-analysis showed decreased risk of large for gestational age, NICU admission, neonatal hypoglycemia, a decrease in mean birth weight, reduction of cesarean, but also an increased amount of gestational diabetes that was diagnosed using that one-step approach. This is compared to a RCT that compared short-term outcomes of 1 versus 2-step screening for gestational diabetes. That was published in the New England Journal last year. This looked at nearly 24,000 patients, and the findings are here on the screen. So there was twice as many patients in the one-step group that were diagnosed, so had more diagnosis. But from outcome perspective, they were similar. There were similar primary outcomes of rate of LGA, perinatal composite outcomes, gestational hypertension, diabetes, and cesarean. And their secondary outcomes were also similar, SGA, labor induction in their treatment. The hypoglycemia was more common in the one-step group. Remember, this was twice as many patients diagnosed in that group. And interestingly, in 39% of patients assigned to the one-step method, the diagnosis of gestational diabetes was based on an isolated fasting plasma glucose within the range of 92 to 94. So from this trial, this differed really from the meta-analysis in an important way. Despite the increased frequency of diagnosis, the proportion of treated patients and perinatal outcomes were essentially the same. From a laboratory perspective, as when we're thinking about the thresholds, the real important thing to keep in mind is that if you have an initial threshold of 130 or greater, you are going to have more sensitivity, and as well as when you increase to 140, you will start to get some decrease in sensitivity, but you will get more increase in specificity. So it's a balance between the 2 tests. Now, the management of patients with marked elevations of their values often comes up. For patients that have a glucose challenge test of 182, greater than 182, greater than 95% of those patients will have an abnormal 100 gram, as well as certainly if it's over 200. So it's very reasonable to make that diagnosis. And this really comes from the data from Carpenter-Kustan when they were looking at all these values to see which ones to set to help to make that diagnosis. Again, this is the example of Carpenter-Kustan versus the National Diabetes Data Group. So Carpenter-Kustan 195, 180, 155, 140. And the initial studies that were done, that certainly also were done with O'Sullivan back in the 60s, used 2 elevations. Now, there was systematic review that was done in 2016 that looked at over 25 studies that also showed that if you had one abnormal value on that 100 gram GTT, There's also increased risks of poor outcomes. But it's in particular with, you may, if that's the case, you may want to be watching for accelerated growth or other adverse outcomes. But there has not been, it's really unknown if there's benefit from treatment. If you gave them the diagnosis of gestational diabetes based on one value, and then you treated it, if that's a benefit or not. And then again, the 75 gram 2-hour test, the values are here. And again, diagnostic criteria is for if there's one elevation, keeping in mind what I had said earlier about if you have one that's 92, that's essentially would give a patient the diagnosis of gestational diabetes, but is also within the range that we look for when we're following patients' blood sugars throughout their pregnancy. Oftentimes it comes up, what are the approaches for patients when they're unable to tolerate an oral glucose load? Maybe they've had bariatric surgery, maybe they've had significant nausea and vomiting in the pregnancy. These are just some ideas of ways to help to avoid that. One could be serving it cold or with ice to help to reduce nausea and vomiting. In addition, pre-medicating patients prior to doing the test. If patients are at increased risk for a dumping syndrome or really are not able to tolerate the testing, certainly can get a glucometer, do fasting in 2 hours postprandial, breakfast, lunch, dinner for a week, look at the values and see and make the diagnosis that way. Other approaches have been attempted but really have not been validated, including giving candy and drinks that measure around 100 grams of glucose. This is not endorsed by ACOG, or using A1C, following A1C throughout the pregnancy. There's no identified threshold of when you would make diagnostic criteria based on hemoglobin A1C. And finally, I wanted to talk some about postpartum follow-up. So essentially, patients that, patients deliver, they've delivered the placenta, gestational diabetes should go away fairly precipitously. But we know that it's estimated that between 15 and 70% of patients will go on to develop diabetes. So the standard of care is currently to screen patients 4 to 12 weeks postpartum with a 75 gram 2-hour OGTT. And really following the algorithm here to determine, is it, yep, I've actually developed diabetes. I've got a fasting of 1 greater than 126 or greater, or developed diabetes. I need to be referred to primary care as well as to endocrinology, or I'm in that challenge of developing diabetes, pre-diabetes. And so I'm in, places where I can make healthy choices. I can, make some more physical activity, maybe referral for the management of those things, medical management, to be on the lookout. And then certainly there's patients that are gonna be normal, and those patients that are normal still need to be followed closely every 1 to 3 years, looking at their glucose to diagnose either pre-diabetes or diabetes. Gestational diabetes in pregnancy is really a moment in time in a patient's life, and we can use that if a patient has developed gestational diabetes to follow more closely. Certainly there are many barriers to screening patients postpartum, getting to their postpartum visits, getting the screening done. Is it gonna, and something as challenging as going through that period of time when you have a newborn. Some have advocated for checking fastings, checking A1C, doing serial A1Cs. These would all be outside. Certainly, I think you have to come up with what works for your patient population. The metric that we are working on currently through the SMFM and other organizations to try to find out, because there's clearly a quality gap for patients. You'll notice this when you start to look and see what your rate is for either screening during the pregnancy or screening postpartum, and where are the barriers and where can you make a change so that you can essentially help patients who are transitioning from having gestational diabetes and making sure that they're optimized after the delivery. This slide represents some of the ACOG practice bulletin recommendations, which include screening all patients for GDM, In the absence of clear evidence that supports one cutoff or another, it's important to choose one for your practice or for your health system so that we're all talking in the same language, essentially, and keeping in mind what community prevalence rates are. Given the benefits of standardization, it's certainly a very reasonable thing to advocate for in your health system. Screening at 4 to 12 weeks postpartum is recommended for all patients who have had gestational diabetes to identify those patients either as having diabetes or having impaired glucose levels. Patients with those levels should be referred certainly back to their primary care provider as well as to other resources. And all patients who have a history of gestational diabetes should receive screening every 1 to 3 years to make sure that glucose levels are remaining in the normal range. So with that, I really appreciate your time and listening and hopefully learning something about gestational diabetes screening. I am certainly available for questions. I'd be happy to answer those and have a good day.